Thank you very much indeed, and I must thank the Congress organisers for accepting my modest abstraction. I feel very humbled to have just heard Professor Whitcamp's excellent talk and very inspirational for me, because it's something that I suppose I hadn't, it's happening, and I've been in denial, as probably many of our colleagues in the UK. I'm really talking, well, in this rather grandiose title, probably should have Nottingham written after the end of it rather than the whole of the NHS, but yeah, thank you very much indeed for your excellent talk. As I say, I wrote with David Eadie a rather negative editorial quite a few years ago. I don't quite know why we wrote it. I think the problem is when you're, well, I suppose he might have been editor and I might have been about to become editor, and I guess we were trying to drum up excitement, any news is good news. There was an article, Systematic Review, that this editorial referred to, and this is really their conclusion, so it wasn't really our conclusion, it's just that I think that the BAD at the time, and probably still does, think this way, and I suppose really we're a bit like the Russian propaganda organisation, and that we were sort of not really the mouthpiece of the BAD, but were. But anyway, I'm sure I'll be struck off now. But anyway, I'm a born-again evangelistic teledermatologist, having, I think, three goes at trying to set up telederm in Nottingham over the last 20 years, and this one seems to be gaining traction. Anyway, let me tell you about what we've been doing the past year. We're using iPhone technology. We're connected to Dermatoscope, which you're all probably familiar with. If not, you can see it up in the coffee room. How it works is the health of this was really brought about by the CCG and Circle, who I work for in Nottingham. They were very keen to embrace technology, and of course well, not mine, but all my colleagues' negativity, hence that editorial, was quite a struggle to get it going. But anyway, the GPs, we had an inaugural meeting with the GPs, and I've never seen so many GPs in a room. It was incredible. If you give a talk to GPs, you might get, 10, 15. We had 60 or 70 crammed in this room. They were keen as mustard to get this going. And I think, the reasons why is, you send a patient up in 6 weeks, well, actually it's probably 6 months later in the UK, you get to see the doctor, and as you say, 2 minutes, you're out, or less if possible. And, well, we have busy clinics. So anyway, the GPs were on board, and they will take the pictures, not many, about a third of our referrals are directly from GPs. They do everything or get their nurse to do it. Then we have the referrals that come in, and if the GPs can't take the pictures, we will offer a service to take the pictures for them. And then, of course, we have our referral letters, as we all see in the NHS, and we go through them and say if it's suitable for telederm or not. And then they're uploaded onto a portal, which is obviously secure and fulfills all the information governance rules, etc. And then and I'll show you an example of it, we send it back to the GP with our recommendations. So we've been going just over a year, and we've seen nearly over 2,000 patients, on average about 175 per month, and I suspect we could increase that a bit, but probably not much more, but it just depends. Actually, with Professor Whitcamp, maybe we can do more. I don't know, it's very difficult. I mean, I can remember Andrew Finley talking about teledermatology diagnoses, and it might have been sort of 1991 or something like that, and it still really hasn't happened. We are still having to see patients face to face, which is something brings shivers down my spine on occasions. So I know, of course, the reasons are, we're doctors trained to have human interaction, and I think many of us don't like the thought of doing it on the telly. But anyway, we're seeing 200 a month roughly, and here's an example taken with that technology, and you can see that there's asymmetry here. And for those of you that know about hand eczema, that's likely, especially when you look at the nails, likely to be fungus, so that's a nice, easy diagnostic one, because obviously it's easier to diagnose lesions than rashes often. And this is very simple what we do. We say the diagnosis, any key findings, and then the recommendations. And we try and discharge as many patients as possible. Here's more photographic examples, just to show you the quality or lack of, but it's still workable. I think this is not a particularly great photograph. It's the GP photograph. And I think noses and ears and lumpy bits are quite difficult to photograph with any camera, let alone an iPhone. But the dermatoscopy shows it looks, well, I think most of us would say that needs chopping out anyway. And I remember when Saul talked at the BAD about teledermatoscopy, you've got a massive screen there, whereas when you just look at the patient, you've just got a little circle you're looking at. So actually, it's easier for me to do dermatoscopy on the screen because I can enlarge it, whereas I can't do that, on the patient's stomach or wherever I'm gulping at. So, yes, I think teledermatoscopy is very useful. Here's another blurred lesion. It isn't very difficult to take a photograph in focus, but anyway, I think even if it was in focus, you still probably wouldn't be able to give a diagnosis with any degree of certainty. But with a dermatoscopy, you can say that needs but either biopsying or excising. Doesn't need discharging. So, and here's this one I found difficult. We asked the referrers, the GPs, to give us a history and examination, and this GP's been very, very, that's all I need. I don't want to know whether they've got, whatever they've got. I'm not interested in their blood pressure pills and all the, you get reams and reams and reams of stuff, don't you? I don't want all that. I don't want it. I know some people might. Anyway, what I want is what question do they want us to answer? What is the point of the referral? And this was, this is a SEB-K, and please reassure the patient. Well, I wasn't able to do that because I wasn't confident that was a seborrheic wart, but actually it was, funnily enough. So it was just as well actually, could have discharged her, I suppose. But anyway, what are the outcomes? Well, we are almost continuing to keep at about 50% we can discharge back to the patients, so they don't need to be seen in the clinic. So that's nice and easy to get seen. Their telederm consultation will occur within a few days, so they haven't got to wait weeks and weeks and weeks. 2-week upgrade, that's a lot, but that's because in Nottingham we count BCCs as, well, we don't count them as 2-week wait, but they go down that pathway and they're seen within perhaps 4 or 5 weeks. So half, well, probably 80 to 70-80% will be BCCs, and then the rest will be SCCs and melanoma. And then, of course, the routine patients that we have to see, the ones with acne, psoriasis, which we do slightly try and discourage because it's about telediagnosis, not telemanagement, but obviously can do telemanagement. Patient satisfaction, which is probably the most important area in my view, and surprisingly, I thought, because when we've done it before, patients will often say, well, I'd prefer to be seen face-to-face, but if it's going to save time, I'm more than happy to have telederm. And actually, it was very, very good. 96% said they'd be happy to recommend this, and you can see all these here. And this, I think, is the key to it. And it also helps to educate the GPs. And inevitably, you get melanomas popping through that the GPs have just missed. Again, you can see this is always a shame when they've had it for decades, and we can sort it out in a few days. And actually, it has led to our general waiting list to come down, and I guess that will continue to come on in due course. So that the money, I think telederm really, other than it being a sort of social, psychosocial problem that many doctors don't want to do it, it really comes down to pounds, shillings and pence. And I think many dermatologists are not keen on teledermatology because if you can see somebody in your private practice for, I don't know, a couple £100, and yet in telederm you've got to see him for 50 quid or whatever price, then you're better off with the 200 quid one, aren't you? So that's what it really comes down to, whether it's private or NHS, is cost. But we've we worked with our CCGs and we've managed to save them 200 grand, which they are very, very pleased with. And my final slide, really, well, no, second to last slide, speed of consultation, 53% were treated in primary care, reduce the waiting time, care closer to home, reducing the patient attendances in primary care, and I think this is a very important thing, because if the GPs get the feedback within a few days rather than a few months, they're much more likely to take it on board. Because if you get referred, then 6 months later you get the letter back from the specialist saying it's X, Y, and Z, you've sort of forgotten about it, really. But I suppose most GPs have the advantage of System 1 in that they can look it up perhaps more easily than we can with our notes and all the rest of it. And my last slide, is it worthwhile? Has it been worthwhile? Will it continue? Well, the patients are satisfied. The CCG, who really are the most important people in this equation, are very happy, so they're keen for it to continue and really try and encourage GPs to do more of it. It gives us extra capacity, and I think this is, again, another important aspect of teledermatology in our department and probably throughout the UK, is it gives you extra capacity. And you can increase that capacity or decrease it depending on the need. And really, I suppose the biggest hurdle that we've had over the decades is to try and persuade our colleagues that actually it is worthwhile. So thank you very much.